Welcome to The Smart Divorce on Divorce Source Radio, helping you move forward with focus, hope, and confidence, saving you time, money, and your sanity as you build a better life post-divorce. I'm Steve Peck. Deborah Moskovitch, divorce consultant, educator, and author of The Smart Divorce, brings you the leading experts and researchers in the divorce arena. We'll also be speaking with those in the trenches, people who've learned from their divorce and how their experience has changed their lives. And they would tell you for the better. Deborah's learned that divorce can be a beginning, even if it looks like an end. Divorce can be rich in opportunity to learn and grow from. And we're going to explore how to take this information and create a positive post-divorce life. And now, here's Deborah.
Hi, Steve. How are you today?
I'm great. How are you?
I'm just fabulous. But we've got something really difficult to talk about today, and it's something that's not often discussed, and that is PTSD, post-traumatic stress disorder. Uh-huh. Now, I know that people relate it to the military, but the truth is, it's not just the military. There are people in the paramilitary, police, firefighters, individuals who have experienced a dramatic event. And I think it's so important to understand what it is. I would really like people, and myself included, to be more aware of symptoms and the impacts on relationship.
I've also heard that it extends far beyond that. It can extend into a death of a family member or even divorce.
Divorce, domestic violence, children of divorce. And that's why I wanted to talk about this topic. I think it's just so critical. And you know me, I always go to the leading experts. And so today we're going to speak with Dr. Robert Cipriano Jr. So Rob is a police psychologist for one of the largest police departments in the United States. And he provides expert training and develops strategies for effectively working with understanding the criminal mind, as well as gaining insight and managing individuals who suffer from severe mental illness and who are in crisis. So, what a better person. Mm-hmm. So, criminal mind, divorce, I don't know. But I'm sure we can tie it all together. And trauma, we want to talk about trauma and violence, out there in the field. And what does that mean to people? What does that mean to relationships? And now that we've got so many veterans coming home, how is that going to impact relationships, society? Both here and, here, U.S., you're in the States, I'm in Canada, and we also have a lot of service members coming home. So what does that mean? So I'd love to welcome Dr. Robert Cipriano. Welcome to the Smart Divorce on Divorce Source Radio.
Thank you so much. I really appreciate you all having me.
Such a pleasure. Just tell us a little bit more. What is the history of PTSD? What's the diagnosis?
That's a great question. Post-traumatic stress disorder was first recognized as a diagnosis by the American Psychiatric Association in 1980. We use a model in our mental health field called the Diagnostic Statistical Manual, and it was first introduced in 1980 in that particular manual. It was called the DSM, was the acronym DSM-3, third revision. Now we're approaching DSM-5, so there's been a few revisions since then. And what specifically it started looking at were an array of symptoms that an individual that experienced a out-of-the-norm experience, in particular trauma, had certain responses and symptoms. And those symptoms were very disturbing and are very disturbing to an individual. We look at it as a response to an abnormal event. And we also look at the time frame. And that was something very significant and still is today. It's one of the most sought out and researched conditions that is being studied specifically in different populations. And one in particular is the military.
So when you talk about PTSD and the impact and the effects, is it more mental health related rather than, you're in a car accident and you fall forward and you're bruised and broken bones? And it's pretty well immediate. Is the effect of trauma immediate, or does it progress over time?
Well, that's a unique aspect. It can affect people fairly soon after. Usually, we look at time frames, and usually we look at a 30-day time frame that the trauma now can possibly affect somebody. If it's resolved, usually within that first 30 days, it's not called post-traumatic stress disorder. It's something called an acute stress reaction. If we start looking at the abnormal event, the trauma that has occurred, and now the person starts experiencing symptoms beyond 30 days, now we're starting to look at post-traumatic stress disorder traits. And if the individual now, if those symptoms/traits start intensifying, we can start getting into more what we call chronic issues that need treatment and need care at that time.
What are those symptoms?
Well, you have a few different symptoms. One of the major symptoms include avoidance of things that remind the individual of the traumatic event. If, let's just say, we're talking about a car accident, or we're talking about somebody being a victim of sexual violence or domestic violence. Now, a trigger could be, for the car accident, trying to get behind the wheel of a car. Maybe the car was T-boned. Maybe the person was spinning out of control and had the thought at the time, I'm going to die. That's usually what actually the automatic thought happens with an individual that perpetuates the process. Another symptom is what we call increased arousal, also known as fight or flight response. The person may be very, very hypersensitive, very vigilant to whatever stressor, to whatever trigger that ignited the response, the array of reactions. Anger outbursts, other startle responses that involve the five senses. Re-experiencing the event. The person is in the here and now, but their mind is actually right back to the day that the trauma occurred. Some people can actually hallucinate, either auditory or certainly a visual hallucination. We also have another symptom called emotional numbing. If the symptom starts intensifying and the person is not getting treatment, that can be a sign that there's more chronic issues going on with that individual that require clinical attention. And then one of the other big ones is increased substance abuse. A lot of individuals that experience trauma, there's a portion of them that may resort to illegal drugs, alcohol, prescription medications to try to cope with the troubling symptoms that I just described.
So is it that people want to numb the pain? For instance, someone who's experienced sexual abuse, domestic violence, and then we'll get into the military in the field, but you want to forget the pain? So
there can be some. I've worked with people over the years that their particular way of numbing may have been alcohol and or prescription medications because they just don't want to deal with it. Again, there's a lot of defense mechanisms that certainly play out in people each and every day. One of them is denial.
Is this a form of shock?
Well, the shock initially can occur, but as the person now goes beyond that 30 days, we start looking at beyond shock. Shock is usually one of the first symptoms that the person may try to, person actually experiences and then tries to actually cope with. But now we're starting to get into the spectrum of responses for the, as the person is trying to cope with this abnormal event, and it's beyond shock at this point.
Deborah, have you ever experienced shock?
No, nothing. And you see, okay, so Rob, I'm going to ask you questions, and I'm going to tell you that my questions are going to be totally naive because you see, I don't understand this at all. And I've never experienced, luckily for me, I've never experienced anything like that. Yes, I've been in a car accident, more than one, but nothing that's so traumatic. So it's not like I would go to my therapist, my shrink, or social work or whatever, and talk it through and make me feel better. It sounds like that's not what's going to happen. It sounds like, I can't even go on any kind of antidepressant and that's going to make me feel better. What is it that's going to make me feel better if I've seen something just so horrific or I've experienced something horrific?
That's a great question. We could take 9/11, for example. 9/11 and what changed our country. There were, obviously, that day, there were a lot of people viewing, both in New York and then certainly abroad, on TV, radio, that would be a classic example of an abnormal event, something that is outside the spectrum of normalcy. Now, depending on that, there may be a portion of individuals that, because of that abnormal event, now start having problems, such as some of the symptoms that I described to you. That may occur within the first 30 days. There may be some that don't. This is a condition that we're starting to realize and do an abundance of research on that has a behavioral as well as a biological cause to it. And without sounding too scientific, it's always the classic question: is it nature or is it nurture? What we're starting to realize as studying this particular condition, that it's both. It's nature and nurture, and it involves the amygdala. The amygdala is an area of our brains that controls sex, hunger, thirst, and aggression, and it also has a portion of it that's tied directly into traumatic memory. And unfortunately, with the trauma that occurs, that traumatic memory, it's very difficult to turn those things off. And that's what one of the main symptoms is the person starts having intrusive memories and flashbacks that disturb their world and disturb their quality of life.
Yeah, like I've seen that, Steve, I'm sure you have too, like in the movies, where you see veterans who all of a sudden, like they're waking up and they're experiencing that horrible situation that they had seen in person.
Let me say this too. When I went through my divorce for a year after, I would have horrendous nightmares about this divorce situation. I kind of thought it was my body's way of working through it, but maybe that could have been classified as this as well.
Well, specifically, that's where we want to look at intensity, duration, and frequency. Here in Western society, here in the United States, we look at those particular categories and we make an assessment based upon, meaning those in the behavioral sciences, in the mental health field, is that condition now affecting that person's ability to function in the real world socially, occupationally, and or legally beyond a 30-day time period on a consistent basis. So if you were dealing with something, let's just say, talking about divorce in particular, if those symptoms started to abate over time, that would not be considered post-traumatic stress disorder. That may be more of an adjustment disorder or what we call an acute stress reaction. If it now goes beyond the 30 days and it affects that person's ability to function in the real world, occupationally, socially, and or legally, now we're starting to get into the realm that there may be some more trauma-based reactions indicative of possibly post-traumatic stress disorder, but we would have to assess that on a week or day-to-day basis.
So how do you help a loved one? Okay, so you're in bed with your partner, and they're having these horrible flashbacks now, and they're really in distress. This person's lying right next to you. What do you do?
Well, I think the first thing that you do, specifically in what I recommend, is to talk with someone whom you trust and talk about the feelings associated with those distressing, intrusive memories and or dreams and or nightmares. That would be the first recommendation. I think the next thing that you would want to do is, if it continues and if it tends to intensify and there's other stressors going on with the individual, now you would want to maybe seek somebody that is specialized in the area of behavioral sciences that really knows what they're doing and certainly can start working and trying to treat that condition.
Okay,
this is a condition that is very, very successful in treating through traditional talk therapy, also certainly psychotherapy, also known as psychotherapy, and specifically responds to what we call cognitive behavioral treatment, how thoughts and feelings tie in with people's behaviors.
Okay, but I'm in bed with my partner. My partner is just flipping out. Do I try to bring them back to reality? What do I do to help my partner?
At that moment, I would recommend that you would listen and that you would provide some type of supportive guidance and trying to self-soothe that individual until at a later point that person may decide, with your feedback, I really need to get in to talk to somebody that really understands this. Now, we're talking about a nightmare versus now if I've had a nightmare beyond 30 days and it seems to play out every night and I'm getting 2 hours of sleep and now it's affecting my ability to function in the real world at work. See, we're talking about, again, maybe apples and oranges. So we want to make sure that, again, those particular criteria, the things that I just mentioned to you, would be something you'd want to keep in mind.
Okay, so it's not like okay, now you're going to think this is like the dumbest question, but it's not like you're sleepwalking, right? And then you wake that person up and you can snap them out of it. This is
That's
something
correct.
that you can't snap them out of.
Yeah, you just don't snap them out of it at the time, and you would not want to say to somebody, get over it, this is all in your head, come on, these things happen in life, whatever trauma you're dealing with. You would want to specifically actively listen with the person, talk with the person, provide support, and get that person to start speaking about what is really disturbing him or her. It's almost like, this might be a better example to kind of help you. When the person goes through the trauma, it's like our brains are almost like cameras. They're on 24/7. So now whatever experience that we ingest through the five senses, now we have to try to process that. Well, if it's something so out of the norm, such as a very severe car accident that now, let's just say, requires 6 months to 8 months of physical rehabilitation, well, there may be nightmares associated with that particular car accident. Let's just say the gas tank exploded during that car accident. Now, all of a sudden, the person now has a response every time they smell gas. It takes them back to that particular trauma in their life. So now we're starting to get into the realm of somebody that may be suffering from PTSD that's gone untreated for 8 to 9 months.
Imagine a battered wife.
Absolutely.
Yeah.
Absolutely. That would be a perfect example. Somebody that is enduring that day in and day out and now is, having such difficulty being able to function day to day and is, just like I covered, so hypervigilant that when that person, the other spouse or other partner comes home, is even more concerned about, receiving a beating or God forbid, some act of violence occurs in that home. So this can actually start turning into feelings of hopelessness and helplessness.
Does that translate into the workplace then? So here you are acting out at home, there's a lot of anger. What happens in the workplace?
Well, that's another great question. Certainly, this can now affect people's work, because remember, one of the criteria is it happens beyond 30 days, these symptoms, and it starts affecting somebody's ability to function in the real world, occupationally, socially, and or legally. So absolutely, the workplace would be a tremendous venue for that to be displayed and manifested, and it can be displayed in particular to coworkers and supervisors that really just don't know what the person is going through. They just see the person very sad. They see the person experiencing maybe they're missing work. That's one of the big cues that we look at is avoidance. So maybe the person's missing work. Maybe they're not productive. Maybe they're having a very difficult time staying on task, and now when you dig deeper, you start finding out that that person is experiencing the symptoms that I just listed.
Now I know why your workshops are so popular. There's certainly a lot to learn.
Absolutely.
Tell us about the fight or flight response to the perception of the danger that an individual...
Absolutely. What starts happening with the fight or flight response, going back to that behavioral and biological example that I gave you, there is that particular area of our brain, that amygdala, that controls those main aspects in functioning. What seems to happen is when more stress or more triggers are introduced, it gets activated. And when it gets activated, it's manifested, it displays it through particular again, through the senses and then through particular feelings, and then from those feelings into behaviors. So the fight or flight response would be if, and again, I'll use, let's just say a divorce. I'll use a divorce. For example, if somebody is getting divorced and there's really negative feelings associated with that, and let's just say it's a very tumultuous divorce, that divorce now acts as such a trigger that the person just totally freezes. They don't necessarily fight or flee. They freeze when they're dealing with something that's very upsetting about the divorce. Say somebody brings it up. Say there's a small child, and that small child is now between two parents and involved in a custody dispute. Just by talking, maybe, let's just say, to an individual that is trying to interview him or her and uses the word divorce, that child now may just clam up and not respond or talk or be able to communicate because they're so scared of the unknown. They already know what divorce feels like because mom and dad or two partners are not together. Now that other aspect is being introduced where somebody is questioning him or her, and they may just respond by freezing. So that would just be one example that I could think of at this moment in time that certainly could be very significant that you would want to look at and question a little further with the right people.
But that's an excellent example, because if the child's parent is experiencing PTSD, there's that trickle-down effect in terms of how it's affecting them. And, you talk about the amygdala, and I don't know, Steve, if you've talked to other hosts about the neuroscience. Now, I've been going to a few seminars, hearing psychologists talk about, Rob, neuropsychology, neuroscience, all about the brain. And there's so much information now that is being learned about how people are impacted by trauma, like how the brain is impacted by trauma. So, and it can impact as soon as you're born, and the attachment theory. Like if you're not attaching to a human, to a parent or to a caretaker, or a caregiver, that is going to affect the way your brain develops.
Well, that's another excellent point. I mean, when you start getting into understanding Dr. Bowlby and attachment theory, you are looking and touching upon aspects of trauma, because what may be traumatic to you may not necessarily be traumatic to me. See, trauma is very idiosyncratic. It's very, very unique. And let's just say there's going to be some children or a parent or an individual that specifically is affected by trauma, and the other person is not. We know we're learning a lot about twin studies, identical twin studies, as it relates to the behavioral sciences. And I can clearly tell you some people are wired, and you used a very good word when you started talking about neuroscience. Some people are wired, and again, that's where they're starting to look at nature and nurture.
So what do you suggest to parents regarding their children if a parent is suffering from PTSD and they want to minimize or try to minimize any kind of impact on their children? What help should they be getting for their children?
That's an excellent question, and I'm glad that you're asking it. One of the things that I really talk a lot about to parents and caregivers and guardians and staff, school administrators, is there's three factors you want to really look at in trying to insulate your children: support, coping skills, and intellect. Those are three major factors that act as insulators in helping people deal with trauma. I can just kind of digress just for a quick second. I went through a very traumatic experience at 8 years old. My mom had to have a major brain operation. At the time, I didn't understand what was happening, and I can clearly tell you it changed my life. After my mom had that surgery, I did not know until I was shuffled around between parents and caregivers for the following month that my mom was in the hospital. Well, when I got back to see my mom that was recovering from the hospital, she didn't know who I was for approximately 1 year. She used to call me kid and child and who is this boy. And I remember I would cry myself to sleep, and I would deal with that in my own way, and I would talk to the people that were closest around me. Well, as the years went by and my mom started kind of remembering, and she was able to get a lot of therapy and a lot of treatment during those follow-up years and medication to control, she suffered from grand mal seizures, that certain things started coming back to her, and we certainly reconnected. Well, lo and behold, look at me today. I work with people each and every day, and I work with their minds. So if that trauma had never happened to me at 8 years old, I may not be a clinical psychologist today. So I look at how that affected me, and again, I had the right support, I was blessed with a good intellect, and I certainly developed coping skills along the way.
See, in my situation, my father passed away when I was 6 years old. And I came home and was told that he was on a business trip and that he'd passed away. And I can remember the anger and crying that night. But from that point on, it's all black to me.
I see.
I don't remember anything but having recurrent dreams that my father had chosen to stay in New York where he died to live with another family. But my mom, back in the 50s, 60s, they weren't really sending people to therapy. And I didn't even go see him at the funeral home. So there was no closure whatsoever. And I'm sure I must have suffered part of this syndrome somewhere along the line.
Well, I certainly appreciate you sharing that experience, and I definitely appreciate that. I think what I'm hearing there is, when you started talking about there were certain parts where you didn't have a memory, that may have been, and again, it's certainly a hypothesis, in what you're telling me, but that may have been your brain's way of being able to kind of shut down and deny at the time something that must have been incredibly scary for you at that young age, because let's just say, at 40 years old, you certainly had different coping skills that evolved and that you built compared to when you were 6. And I definitely, like I said, validate what you're saying and appreciate you telling me that. But you can clearly look at a couple of different factors there. You can look at, what may have transpired throughout the years where you may have had some nightmares, or you may have had some negative feelings, or some feelings that made you feel uncomfortable whenever that topic was broached upon.
Right. And Deborah, I wonder, when children go through this today, we know that divorce statistics show that children of divorce get married at a lesser rate than children in whole families. So I wonder if some of these children are hanging on to this, and this is, it brings back bad memories when they start to think about getting married. Maybe that's something that holds them back.
Well, they say, obviously, and from these examples, Rob, thank you for sharing your story as well. It just goes to show how your past influences your present and who you are today.
Absolutely.
You take, and we're very fortunate that you took your learning and, and same with you, Steve, like you took that experience, but you've turned it into something, positive in terms of what you're giving back today. And I guess I could say the same thing about my high conflict divorce and what I learned. And I believe that, certain opportunities, it depends on how you look at them, right? Like, wouldn't you say, Rob, like either the glass is half empty or half full? And so.
That's true. Absolutely. And I think, it just depends on, and again, using these two illustrations, Steve at 6, me at 8, what if these had happened to us, these traumatic situations had happened to us at, let's just say, 14, 15, 16, or let's even just kind of look at it on the contrary at 3 or 4. So it just really depends on, you're looking at multi-variables, and again, it's not a panacea, but we can certainly, hypothesize at 8, that must have been the right age for me at that time, at 8 years old, to be able to kind of deal with it and then develop some specific coping skills to kind of pull me out of that depression and out of that sadness at that particular time. And one of the other things that really, really became very instrumental for me was sports. Sports really started becoming a major part of my life into, my middle school years and into my high school years, that got me through a lot of some of those residual effects with my mom.
Right. Would you say that if not handled well, like I would think naively, so I guess because you two are proving me wrong, but a lot of individuals would turn delinquent?
Absolutely. That certainly can be a factor. I'm not saying that is a cause and effect. It may be more correlational, but certainly structure, and I'll kind of be a little bit more global, structure is a very, very important subtype of support. So the right structure at that particular moment is very, very important. And if you have someone that is going through a divorce and a very highly charged trauma, such as a divorce, the lack of structure can actually become problematic.
So you know how people, to me, I've learned so much that, we all know that domestic violence, sexual abuse, it knows no boundaries. You could be rich, poor, fat, skinny, beautiful, not so attractive, black, white, yellow, whatever it is. There are no boundaries to what the impact and who is impacted by sexual abuse and domestic violence. We could say the same thing about PTSD as well.
Absolutely. And again, we're just scratching the tip of the iceberg. There's certainly a lot more study that the behavioral science and the medical professionals are looking into, and we have a lot more work to do.
You mentioned it was treatable, but is it treatable years down the road? Let's say you and I both suffered this, and we've held it together somehow all these years, but we still suffer from it. Can you get therapy for it 20 years, 30 years later?
That's another great question, and certainly just to kind of clarify, and I'll just speak for myself right now, since you kind of alluded to it. It would not be coined post-traumatic stress disorder based upon it doesn't affect our ability to function in the real world, both socially, occupationally, and/or legally. So what could be happening, and again, speaking in my case, is I may have, let's just say, a trait that maybe takes me back to that time of my life, let's just say, of residual, for example, hypervigilance. Hypervigilance when I see somebody going through a real hard time or a particular medical situation that now is affecting a child's life. See, I would be highly sensitive to that because that happened to me. But that does not mean that I have PTSD. That just means I have a trait, one of the 8 to 9 characteristics that I was specifically talking about. That doesn't mean that I have PTSD. But that trait, that issue, absolutely years down the road can be worked through in traditional psychotherapy and/or, depending on the severity of the problematic issue, with medications. Certain medications do treat that. And right now the research is at both medication and psychotherapy, traditional talk therapy, are the best mechanisms to treat the actual full-fledged condition.
What type of medication?
Well, we're looking at a few different things. We're looking at something that we call specific types of antidepressants, and some of those antidepressants are called SSRIs, selective serotonin reuptake inhibitors. And without getting too scientific and without getting too into the medical realm, because again, I'm not a psychiatrist, I am a clinical psychologist, but I do know a specific amount of information surrounding medications. What they do is they actually control the level of serotonin in the brain. They also work with another neurotransmitter that we all have. We have dopamine, we have GABA, we have norepinephrine. These are all neurotransmitters that fluctuate throughout our brain, and these antidepressants either suppress the synaptic response in the brain, or they actually increase certain levels of the synaptic responses. So it really just depends on the medication, it depends on the individual, it depends on the dosage, it depends on the frequency, and it depends on the milligram when we're starting to talk about medications.
So, I've also heard of medications like antipsychotic drugs. Would that be something similar to what you're suggesting as well? And can you just explain that a little bit more?
Sure, absolutely. The antipsychotic drugs, what they do is they control the level primarily of dopamine in the brain. And the antipsychotics, too much dopamine synaptically firing in the brain can cause what we call psychosis, separation from reality. Too little of it can actually cause Parkinsonian-like symptoms, where somebody is having tremors and is having maybe a difficulty with walking, and their gait is somewhat challenged. So yes, it does. Some of the antidepressants do act in that way, and you have older antidepressants, and you have some of the newer ones like the SSRIs. But one medication in particular right now is being used at pretty significant rates. Again, it's in the classification of selective serotonin reuptake inhibitors, and that particular medication is one of the main medications that I've seen used with post-traumatic stress disorder, and that is Zoloft.
Yeah. I know people that are, severely depressed and are on Zoloft and Prozac.
Yes.
So those just seem to be well-known antidepressants.
So, Rob, do you recommend when a family goes through divorce, and if you have children young and it was a high-conflict divorce, is it a good idea to seek therapy for them just automatically prior to seeing any symptoms, or should you wait?
Well, what you want to do is you always want to go to the source. You want to ask the child. You want to see how the child is responding. You want to see if there's any signs of their vegetative functioning. Are they sleeping too much? Are they not sleeping? Are they having nightmares? Are they eating? Those are some of the main things that you want to assess with a child. And then from there, you can decide if it's now going beyond the 30-day time frame to actually get the person some assistance. If it's still within the realm of 30 days and the person seems like the symptoms are getting a little bit better, then, as long as that person has an open line of communication, they may subside. Because, again, you want to look at those three areas that I've covered: intensity, duration, and frequency of those symptoms that I covered.
Mm-hmm. And who should they seek out if they think there's a problem? Do they have to go to a psychologist, psychiatrist? Where do they start?
That's another great question, Steve. What you have is, again, that may be very unique to that particular individual and or family of origin. There may be somebody that may want to speak with, they may feel comfortable speaking with their pastor or their minister, somebody in that they feel very, they have a trustworthy reciprocal relationship with. So it really just depends. Certainly the behavioral sciences, individuals that have experience and specific training in understanding the behavioral sciences and the mental health field, that would be an area that certainly, again, they have research. As a clinical psychologist, everything that we talk about as far as theories, we always back that up with data. That's one of the unique aspects of psychology, is we don't just do something just to do something to see if it works. We look and really evaluate data.
Well, in terms of data, let me just ask you something, because there seems to be a lot of myths surrounding PTSD and some magical thoughts. What do you have to say about that? Like, what are some of those myths and magical thoughts?
Well, some of the magical thoughts, going back to fight or flight, can be, that whole avoidance response. That, if I now talk to somebody, now that's going to label me, and there's a stigma associated with it. I haven't really talked much about stigma, but stigma is what I call a very poisonous seed that acts as a barrier and an impediment for somebody getting treatment. And it's very, very important, as best as can be, that individual that, let's just say, is going through the traumatic experience, that feel that connection to be able to talk and normalize that person that he or she is speaking to, normalizes that it's not every day you go through a divorce. So absolutely, you may have some specific residual effects. So you really want to normalize to that person so they don't feel that there's such a bizarreness, so to speak, that they're the only one on this planet that has maybe this symptom or that symptom. So first and foremost, part of the magical thinking is pilfering through that stigma.
Now, is there really that much of a stigma? I would think that someone who's seeking out help would be applauded to try to do something positive for themselves.
Well, It just really depends on the particular domain. I can clearly tell you within the military and the police force, in my experience, is that the stigma is quite significant because basically there's an underlying dynamic that's implied that you're weak and you can't hold your own and you can't protect me if I have to rely on you as a backup.
Interesting. What about the divorce rates within the military and the paramilitary? Like, what are some of the possible causes and concerns?
Well, I think you're looking at some of the major areas that are being researched and studied. I mean, one of the major issues that I can tell you from case-to-case examples when I'm working with military as well as families as well as the paramilitary environment, working with police officers, is the stress of the position, is the travel, is the separation from family. It's almost like a magnet. It almost pulls you away. It's almost like another marriage, so to speak, that pulls you away from the ones that you love the most. And again, one of the major factors that certainly helps marriages and helps people that are dealing with just life circumstances is communication. So a lot of times communication is certainly compromised.
Not surprised. Rob, I could talk to you for hours about this topic. It's so fascinating, don't you think, Steve?
Oh, it's amazing. I'm wondering about people that have had PTSD, like in the military or a police officer, and they've sought treatment for it, and now they're back on the job, and they're back in these very traumatic situations. Do you build up an immunity to this? I mean, how can you continue to put yourself through this type of situation over and over again?
Yeah, like being redeployed.
Absolutely. Sometimes during the redeployment, 2, 3, 4 redeployments, absolutely, that can actually start building a lot of anxiety with an individual to where now, again, those particular responses that I talked about, the hypervigilance, the fight or flight mode, the freeze mode, all of those things start now manifesting within that person and within that family system. One of the things I just want to clarify before I continue a little bit more is trauma is accumulative. So whatever happened to, let's just say, this individual at, say, 8 years old, now when they deal with something at 13, 14, 15, 20, 25, unless those issues are resolved, that will now start building, and it can start building and adding to that anxiety response. As it relates to that question that you had asked me, I can clearly tell you, in my experience working with both paramilitary as well as military veterans and families, that it really just depends, again, going on to how that individual has responded. Have they worked through their issue? Let's just say if they had some residual effects. Are they now viewing another redeployment as an opportunity, or are they viewing it as a death sentence? Are they developing additional coping skills? Do they have a very well-connected support system? Are they using alcohol and or drugs to cope with their deployment and their time where they're going to be away from their family? So there's a gamut of different things and factors to look at, and again, each case is case by case.
Well, in the military, if you lose your leg or your arm gets blown off, you get a Purple Heart and you get to go home. If you're diagnosed with PTSD, you get sent back to duty. Is that right? Does that make sense?
Whoa, what a great question.
Well, one of the things that the military is trying to do is they're certainly trying to identify if somebody is truly experiencing these effects of PTSD, post-traumatic stress disorder, and they're trying to get them help. They're trying to get them treatment. There's a very proactive effort now being utilized by our military that was not in effect in 1980, and 1982, 1984, 1985. So we've come a long way, and I can clearly tell you in my work with the police, we're really trying to also assist helping officers as well as their families in educating them on the signs and symptoms. A big part of this, Steve and Deborah, is education. Education is empowerment. Empowerment overcomes fear.
Oh, I like that. Is there a correlation between PTSD and suicide?
There is definitely a correlation, because what starts happening is, as the individual is dealing with, and I'll just use this one variable, as the individual is dealing with those symptoms that I discussed, at some point, if those symptoms don't abate and that person is starting to feel more and more like options are running out, suicide, unfortunately, starts becoming a little bigger and gaining more traction in the individual's mind. And unfortunately, I have seen some individuals that have resorted to that, whether it be an attempt and or a completion. So suicide rates are very concerning, and I know there's a lot of work and a lot of study on that right now.
So what are some of the important questions to ask when assessing for suicide with someone who might be suffering from PTSD?
Well, you want to look at a few different things. You want to look at intent. Does the person have a plan? Are they thinking about it? Have they tried other options as opposed to now going down that road of suicide? So it's beyond just a thought. Are they now looking at a particular plan? Are they thinking about trying to initiate some specific plan to end their life? And you want to look at their means. Do they have an availability? Do they have a firearm? Do they have some type of way of doing that, unfortunately? And is this planned? Is it impulsive? There's a few different things when you start looking at suicide threat assessment. When you start looking at the intent, is the purpose for the behavior, is there death, is it communication? In particular, military and law enforcement, big area is embarrassment. Somebody gets arrested. Somebody gets something that's very embarrassing, and embarrassment turns to humiliation very, very quickly with somebody that is, going down that road, and certainly that becoming a viable option.
So is the family at risk too, like whoever's living at home with the individual that really is suffering from PTSD? Are they at risk for serious harm?
Well, there is some discussion right now. Are we looking at PTSD families? And does this extend beyond the individual? I can't begin to tell you the families that I've worked with over the years. They're suffering as well. Now, whether or not they're suffering suicidality, I can't comment on that, but I can clearly tell you that they're dealing with very, very difficult things ahead if the person does not get treatment. So certainly you could only imagine dealing with somebody with these symptoms that goes untreated, that person's main support system and those immediate family members and close friends are also affected.
Unfortunately, we're going to have to wrap this up in a couple of minutes. So what are some of the things, the key, that we haven't talked about that you think are just so critical that people should be aware of?
Well, I think, again, you want to look at those three areas. You want to look at support, certainly, the intellect when we're talking about a child that's dealing with some type of trauma, whether it be a domestic type of trauma or, God forbid, a sexual trauma that actually occurred up, in the Northeast that was publicized all over the United States. Those victims were clearly untreated for years and years and years, and now are coming to light, and that's certainly affecting them as adults. So I think you got to look at a few different things. You have to look at, making sure that there's plenty of support for that individual, letting them know it's okay to speak, letting them know that stigma certainly is a barrier, and the more you stigmatize an individual, the more that person shuts down, and it becomes an impediment for them to be able to seek help. Letting them know it's okay to ask for help, and making sure that person is seeing somebody that really is well-trained in understanding all the facets to this condition and what we know up to 2012 currently.
Rob, if our listeners want to get more information on this or more about you, how would they go about doing that?
Well, I appreciate that. My information is via my website. You can certainly reach me at www.sim, that's S-I-M, C-I-P, group.com. And that is my website. And certainly my email is another way of getting a hold of me. And again, if you access my website, you'll certainly see my email, which is info@simsipgroup.com.
And we're going to have that posted also on this page. So thank you so much, Dr. Cipriano. It's been
so much, Deborah.
Incredibly informative.
You're welcome, Deborah. You've done it again. Brought us another all-star.
I told you.
You did. And listeners, if you want to write us, you can at divorcesourceradio@gmail.com. Deborah, thanks again. We'll look forward to another show with you next week.
Looking forward to it. Have a good evening.
Thank you. You too.